Very good evening, respected chairpersons, colleagues, and participants. I would like to thank the organizers and Association of Plastic Surgeons of India for making me part of this exciting module on cleft lip and palate and its care. The topic assigned to me is velopharyngeal insufficiency, evaluation and management, along with speech therapy. Nothing to disclose. Before discussing velopharyngeal incompetence, we must know what exactly is velopharyngeal port. It's an orifice at the junction of nasopharynx and the oropharynx. It is guarded by a velopharyngeal sphincter. Anteriorly there is soft palate, posteriorly is the posterior pharyngeal wall, and lateral border is formed by lateral pharyngeal walls. It's a complex three-dimensional muscular valve consisting primarily of levator villi palatini arising from the skull base and inserting into the palatine aponeurosis. Along with that, there is superior constrictor, palatoglossal and palatopharyngeus laterally, and musculus uvulae in the midline. All these muscles contract together to cause posterior superior movement of the velum and attempt to close the velopharyngeal port. Primarily, there are three patterns of closures. Coronal is when there is primarily velar elevation only. Only the soft palate elevates and closes the port. Sagittal is when the lateral pharyngeal walls move together and try to come in midline, and velum contracts the lateral walls rather than the posterior wall. Again, the closure is there in this form. More common is the circular closure, in which there is medial movement of the lateral pharyngeal walls as well as velar elevation in near equal proportion, and velopharyngeal port closure is achieved. The primary function of velopharyngeal port is coupling and decoupling of nasal and oral cavities. The port remains closed while we are eating and prevents nasal regurgitation, and it also allows for production of oral consonants while being closed. But this port opens up to allow for breathing and also help us in producing nasalized articulations like m, n, etc. So in case of velopharyngeal dysfunction, there are problems like hypernasality, nasal air emission, compensatory articulation errors, all of which lead to poor speech intelligibility, and all of these lead to stigmatization of the children with cleft deformities. Unrepaired cleft palate is the commonest cause of VPI. Besides, in case of repaired cleft palate also, close to 15% end up with some incompetency. Besides, other structural causes could be submucous cleft palate, palatal fistula, congenital short palate, or other causes of palatal insufficiency. Another important cause could be you have achieved a good palatal closure, child is speaking normally, patient undergoes mid-facial advancement, he or she may end up getting a VPI. In addition, neurogenic causes include cranial nerve palsy, CVAs, myasthenia gravis, poliomyelitis. Of course, we are not discussing these in this presentation. Evaluation includes both clinical examination and instrumental evaluation. Clinical evaluation includes detailed intraoral examination, assessment of the reflexive behavior of the child, as well as voluntary phonetic behavior. While doing intraoral examination, you must check for symmetry of velum, tonsils, and soft palate. Especially in cases of submucous cleft palate, when you see a bifid uvula, you must palpate for the notch, and obviously you will see a zona pellucida. Use a good lighting to check for any oronasal fistula or any fistula at the junction of hard palate and soft palate, and also check for velar motion as you tell the patient to do sustained phonation. Reflexive behavior examination will give you a general idea about the dysarthritic status of the child, and you can also find whether there is asymmetry, fatigue, delay in speech, or lack of response on the part of the child. Also check for the history of any nasal regurgitation. That will give you an idea about the level of incompetence. As far as voluntary phonetic behavior check is concerned, it can be done only in case of elder child and patients who are really cooperative. Next, you will send the child for speech evaluation, and you will come across terms like resonance quality, airflow, air pressure, compensatory articulation, etc. Let's learn a bit about each one of them. Resonance is the nasal vibration produced during vowel production like I, U, E. And in VPI, there will be hypernasal resonance. You can get an idea by comparing the production of these words with occluded as well as unoccluded nares. Airflow gives an idea about presence or absence of nasal air emissions. They may be audible or inaudible. However, presence of nasal flaring and grimacing while talking gives an idea that child might be having VPI. Most definitive test is the mirror test. You ask the child to pronounce S in a continuous manner, and in case you find leakage of air or fogging on the mirror, there is confirmation that child is having a VPI. Similar results may be found by deflection of tissue paper. An average adult requires a pressure buildup of around 5 to 7 centimeters of water in the oral cavity for production of oral consonants like plosives, like p, fricatives like f. But in case of VPI, there is inadequate pressure which is developed and which is secondary to incompetence. And the child tries to articulate a different anatomical area and produces sounds which are different from what was intended. This is called as compensatory articulation. Common compensatory articulations include glottal stops, in which the child is unable to speak words like t, d, k, g, and they are replaced with a pop sound which is produced from the vocal cords directly. And similarly, the nasal fricatives like s, f are produced through the nose instead of mouth. Another thing is that pharyngeal fricatives are produced in the pharynx instead of mouth. So all of these lead to a classical voice which used to be known as cleft palate voice. To objectify the speech disability, perceptual speech evaluation has to be done, which tests both spontaneous as well as provocative speech. And the commonly used scale is Pittsburgh weighted speech scale. In this, the various parameters like nasal emission, facial grimace, nasality, phonation, and articulation are graded, and to arrive at a final score. A score greater than 7 is considered Velopharyngeal incompetence. In case perceptual evaluation reveals VPI at multiple evaluations, the child is straightaway sent for instrumental evaluation. However, in case the VPI is intermittent, trial of speech therapy is given, and only when the VPI persists, then only the child is sent for instrumental evaluation. The goals of instrumental evaluation include finding the data about the adequacy of velar length, the palatal elevation, velopharyngeal gap, excursion of lateral pharyngeal walls, as well as nasopharyngeal depth, and pattern and level on attempted closure. Various aids for visualization of the nasopharyngeal port include lateral cephalogram, multi-view video fluoroscopy, nasal endoscopy, and MRI. Lateral cephalogram provides idea about the length and configuration of the velum, shape and depth of the nasopharynx, maximum velar height and contact, and as well as about the approximation of the posterior pharyngeal wall while producing a static sound. And it can have a greater than 90% prediction of need of the pharyngeal flap, as well as it can give some idea about the dimension of the pharyngeal flap required. However, there are certain shortcomings also, as lateral cephalogram does not assess the connected speech, as well as we get to know about the closure of velopharyngeal port as a two-dimensional structure only, and it is difficult to see the small gaps without contrast. A better modality is multi-view video fluoroscopy, in which three views are taken: lateral, frontal, and basal view, and it gives assessment in three planes: sagittal, coronal, and transverse. Additional benefit is we get a dynamic view during the connected speech from beginning to end. Additional advantages are it gives a direct and 3D view of velopharyngeal port. It can take actual measurements and which help in planning the surgery, and it may work for younger children. Disadvantages include radiation exposure to eyes and thyroid, and it requires cooperation from the child because child has to sit motionless for best views, and it requires injection of barium into nares and also requires a highly skilled examiner. Another modality is nasopharyngoscopy using a flexible fiber optic endoscope. Usually a pediatric scope of 2.1 to 2.4 mm is used. It gives a view of velopharyngeal port at rest and during speech. It permits visualization and evaluation of velopharyngeal structures like velum, posterior pharyngeal wall, and lateral pharyngeal wall. Advantages are there is no radiation exposure. It is more sensitive for small gaps, including submucous cleft, occult cleft, levator dehiscence, and it gives a better evaluation of palatal and pharyngeal anatomy. Surgeon visualizes the anatomy and is also helpful in post-operative assessment. And overall, this is a more cost-effective strategy than radiographic study. Of course, it requires a cooperative child, usually more than 5 years of age, and highly skilled examiner. And sometimes the secretions interfere with the image, and sometimes the nasal anatomy is such that you cannot pass the scope. And another disadvantage is that there is a reduced view of lateral pharyngeal walls. Another diagnostic modality is MRI, and the significant advantage of this modality is that it gives you direct visualization of all the velopharyngeal structures, including the muscles. You can find out about the length of the velum, depth of the pharynx, size of the velopharyngeal gap, and this you can do at rest as well as during speech. It is non-invasive and radiation-free and remains a safe option for children and adults both. And recently there have been reports of use of dynamic or cine MRI to see the movement of the velum, but the protocol of this are still being developed. So after instrumental evaluation, you come to know whether the velopharyngeal port is closing completely in case of VPI or it is not closing. In case it is closing completely, straight away you can send the child for speech therapy. Or in case it is not closing, then the child becomes a candidate for surgery. Management option for VPI includes speech therapy alone, surgery, or in some rare cases, prosthesis. Speech therapy aims to maximize oral pressure for consonant sounds. It improves strength and elevation of velum and improves the overall oral motor skills. It can establish correct articulatory placement as well as maximize the oral pharyngeal articulatory function. It is generally helpful in case of minimal VPI or VPI with articulation errors and in post-operative patients. However, it is not helpful in cases of structural deficiency. In structural deficiency, the choice of surgical procedures include intravelar veloplasty, Furlow's double opposing Z-plasty, pharyngeal flaps, sphincter pharyngoplasty, and posterior pharyngeal wall augmentation. This is an important surgical algorithm after instrumental assessment. In case there is a minimal central gap, you have to look for the muscular uvulus status. In case there is notching, then you can try doing intravelar veloplasty. But in case you feel that there is a bulge in the muscular uvulae, then you can try furloughs to increase the length. In case of a moderate central gap, sagittal gap with the lateral wall motion present, you can try doing pharyngeal flap. However, in case of large central gap or adynamic gap or coronal gap or circular gap, and also in which the lateral wall motion is deficient, you might have to do sphincter pharyngoplasty. Redo radical intravelar veloplasty works in case of minimal central gap in which there is a small midline gap with attempted VP closure with uvular diastasis, or in case you know that patient didn't have a good intravelar veloplasty. Furlow's double opposing Z-plasty works with less than 2 mm central gap with good velar movement. This is Z-plasty of nasal and oral layer giving a lengthening of around 2 to 3 mm. Pharyngeal flap is indicated in case of central gap with good lateral pharyngeal wall mobility. Full width of posterior pharyngeal wall is used for flap and depth of 2 prevertebral fascia is used. Flap raw area is covered to reduce shrinkage and lateral port control using 10 French wide nasal catheter is done in an attempt to reduce post-operative hyponasality. Sphincter pharyngoplasty is indicated when there is lateral wall motion deficiency with good anterior-posterior motion of the velum. It provides a dynamic and adjustable velopharyngeal sphincter. The lateral pharyngeal wall flaps are elevated along with palatopharyngeus, salpingopharyngeus and superior pharyngeal constrictor, and they are sutured high in the posterior pharyngeal wall in a crossover fashion. This narrows the space behind the palate and helps the velopharyngeal wall to close. Rarely prosthesis is indicated when the patient is unfit or unwilling for surgery or as a temporizing measure until surgery can be performed, and also in cases of myeneural deficiency or in patients with unstable upper airway or hypomobile velum. Prostheses are broadly of two types. Palatal lifts are used when there is adequate palatal length and dynamic motion of palate is poor. A bulb is used when length is also short in addition to poor dynamic motion. To summarize, evaluation of a child with velopharyngeal incompetence requires a multidisciplinary approach. Perceptual speech assessment clinches the diagnosis, and the visualization of velopharyngeal anatomy using video fluoroscopy or nasoendoscopy or both is very essential so that we can decide the appropriate surgery, which might include pharyngeal flap, pharyngeal sphincter, or soft palate lengthening only. The aim is to optimize speech with minimizing the risk of obstructive sleep apnea. With highly motivated patients and family, it is possible to consistently achieve good speech outcomes in all of these patients. Thank you for your patient listening.